Well, good morning. I have it just a few minutes after 9 o'clock, so we should probably get started on this. This is Pcep for August. Pcep for August is discussion of ACS, acute coronary syndrome, and Stemi. We'll do it actually in the order of Stemi and then acute coronary syndrome. So, how to read an EKG. This is going to be basically It's not even EKG 101. I'm assuming everybody here knows how to read an EKG, but it's that we need to practice reading EKGs much more, or ECGs much more, and specifically a 12 lead. So this is the basic format of reading an electrocardiogram. You notice we're going to start with rate and rhythm. We're not going to talk much about rate and rhythm today, but this is the first thing you look at when you look at an electrocardiogram. Is it normal? Is it normal rate? Normal speed? Is it slower? Is it too fast? Is it a regular rhythm or an irregular rhythm? And if it's an irregular rhythm, is it an irregularly irregular rhythm or just randomly irregular? Look at the axis. We're going to talk about the axis in a minute, so don't fret about that. Look at the QRS duration, and this we're using to decide whether this is a wide complex QRS or a normal or narrow complex QRS. Look at the morphology. Is it a normal looking QRS or is it abnormal QRS? We're going to talk about mimickers for STEMIs, and we're going to talk about STEMI. And then the most, I will continue to come back on this one. What is the context in which you are doing the electrocardiogram? By this, I mean, are you doing this electrocardiogram because the person is a 55-year-old male who has a family history of heart disease, who is now having crushing substernal chest pain radiating to his jaw and to his left shoulder? Is he diaphoretic? Is he having shortness of breath, etc.? That is more likely than if you read your 12 lead and it looks like a STEMI, that's probably what it is. If he's having abdominal pain and having no other symptoms, and he has a history of ulcers, and you're just getting the 12 lead because you're just getting the 12 lead, it probably puts it, especially if you've gone through some of his risk factors and he has no risk factors, and he's complaining that he's been having some tarry stools lately, and you do a 12 lead, it's easier to interpret. It's less likely that it's going to be positive for a STEMI, even if the electrocardiogram doesn't look perfectly normal to you. So contextually, you have to we never treat the EKG, we treat the patient. So how to read a 12 lead? Rate and rhythm. Note the pace. Is it fast, slow, normal for the presentation? If he's if he's running a race and you just happen to do a 12 lead, like as if you're doing a stress test on a patient. When we do a stress test, we run them to almost maximum exertion and then do the 12 lead again at that point. And of course, they're going to have a fast rhythm. That's the normal thing. Your pulse increases because of exercise. Look at the rhythm. Is it regular or is it irregular? Is it if it's a wide complex, it is very likely ventricular until proven otherwise. So if you have a fast rhythm with a wide complex and you're unsure what the source is, it's safest for the patient to assume this is a VTAC rather than a supraventricular tachycardia with a wide complex. Now, of course, we see lots and lots of cases of atrial fibrillation with aberrant conduction, which gives us a wide complex. Now, I'm going to get rid of axis very quickly. We used to spend a lot of time trying to teach people, including physicians, how to read axis. The basic thing is to look at this. You know, the axis refers to the primary directions of the vectors that are coming from the electrical activity of the heart. You know, the 12 lead it's like a camera and it's looking at the heart in 12 different directions, but it's and an upward deflection always means that the primary electrical vector is coming toward that camera lens or that electrode end. We like to look at this at the heart then in a 360-degree circle. You break the circle up into 4 quadrants. What is called left axis, or primarily left axis, is the area from 0 to -90 on the compass. So it's in that right upper section. Normal axis is from 0 to +90. So-called right axis, which would indicate that the vector forces are primarily coming out of the right ventricle, the right heart. Right axis is +90 to +180. It's also -180 if you're looking at it the other direction. And then indeterminate or extreme right axis is that area between +180 and -120, roughly. Indeterminate is up at the top end, but it all falls into extreme right angle. Now, what does this mean? And the easy way that I learned to look at this is to look at only lead 1 and lead AVF. And if it's normal, in the primary QRS complex is upright in lead 1 and lead AVF. In left axis, the primary is up in lead 1 and down in AVF. And right axis, it's down in lead 1 and up in AVF. And in extreme right axis, it's down in 1 and down in AVF as well. Now, this is relatively easy to commit to memory, but the beauty about this is that the machine, your 12 lead reads the axis for you. It will tell the axis, it will tell you the axis. So all you have to know is where, if it says it's -90, you know, or -75, you know you're a left axis. If it says it's 0, if it says it's 45, you know it's normal, or even 90 is normal. if it says it's 120, the axis is plus 120, then you know that it's a right axis. And extreme right will also tell you then if it's somewhere between minus 120 and minus 180. So all you have to do is know where those things are. Now, left axis deviation in the context of your 12 lead will usually suggest a left anterior fascicular block. The fascicles are part of the uh, bundle branch, so that it's part of the that'll give you an incomplete left bundle branch block. An inferior MI or it comes out of a paced rhythm. Paced rhythms will have left axis deviation. It's prime because it's the left heart is the left ventricle is stimulated after the right ventricle because we place the leads for the pacemaker inside the right ventricle. Right axis deviation in this area here suggests probably a left posterior fascicular block. So again, an incomplete bundle branch, but a left posterior fascicle, or a lateral MI, or right ventricular hypertrophy, or acute right-sided strain. You might see right axis deviation, for example, if somebody has a pulmonary embolus, because you're going to get an immediate right heart strain. Extreme axis deviation up in this corner quadrant suggests ventricular tachycardia or electrolyte derangements or even more common, misplaced limb leads. So always check your limb leads, make sure they're correct. Now, QRS duration. Normal is up to 0.12. So if it's prolonged, it is a wide complex. That's our wide complex. It's pathologically wide complex. Note the QT interval. Now, this is another nice thing that happens with the new 12 leads, is that it will tell you the QTC. The QTC is the QT calculated, but it tells you all those things. It reads the QT for you. The QTC for men should be less than 450. That's all you have to remember. And for women, the QTC should be less than 460. And that's, again, all you have to remember. It's a normal QTC if it's under. Now, in extreme rate, the QTC may be reading a little, it may read a little short, but that shouldn't be the problem. So it'll tell you that. And you notice it also tells you the QRS axis. So this one is a minus 56. So he's going to be a left axis. So how can we put this sort of together to help us? This is a case that we had recently. It's a 25-year-old female, which they went on found her in cardiac arrest. That in and of itself is somewhat unusual. It's a history of alcoholism. She'd had trials of rehabilitation, but had always rebounded. So she continued to drink, although she hadn't had any drinks that anyone knew about for a couple of days. And she'd been complaining of uh, nausea, vomiting, and then was found in arrest by family. Uh, when they first got there, they had they got Rosk with CPR alone, but then the patient had multiple episodes of VTAC, probable torsades, although I didn't find any. Didn't capture any on their any of the things that I saw, and then once again possibly VTAC or VFib. She received MAG, amio, multiple defibrillatory shocks. She was transported to the ED with pulses and blood pressure. She rearrested in the ED. She was treated again with uh, uh, more MAG, etc. Now, if you look at this out, obviously this is an abnormal 12 lead. It was read by the machine, and that's my first thing. Don't trust these machines necessarily. This is read as a flutter. Um, not sure whether that is a flutter or not. There, but they are reading that if you notice, the QTC is 472, so it's above normal for females. So that would imply to you that indeed she probably had, if a prolonged QT would make me think much more that the patient was going to have ventricular ectopy and even torsades. Now, remember that this particular 12 lead was taken after she'd already been treated with magnesium, with amio, uh, and had some defibrillatory shocks. So theoretically, if she had a prolonged QT on the basis of a electrolyte disturbance, her QT would have been higher than that, and would have been brought down by the treatment. And indeed, when she got to the emergency department, when she did arrest again, at that time they had a QTC of 572. So her QTC was prolonging again, um, uh, likely because of her uh, electrolyte abnormalities. So history of alcoholism is essentially a disease of starvation, uh, and you get you get low on a lot of things, including magnesium, especially if you're having nausea and vomiting. Magnesium, potassium, some sodium, but mostly magnesium, potassium, and chloride by vomiting. Um, so the 12 lead gives a very good hint as to what was going. Incidentally, she was stabilized and was, the last I knew, was in the ICU. I don't know what kind of neurologic function she's likely to have out of this, but um, look at the morphology of the QRS. If it's greater than 120 milliseconds or 0.12, check V1. V1, you're looking for the terminal R wave. So terminal R wave is the last wave deflection of the QRS, and if it's an upward deflection, which is an R wave is upward deflection, then that's a right bundle branch pattern. If there's even an R, small r with a deep S wave, in other words, a negative deflection in V1, that by definition is a left bundle branch block. Now, if it's a QS, that's also a left bundle branch block. So no R wave at all. But the R wave can be there. It can be there. It can be small. So right bundle branch morphology, lead V1. So this will give you the little rabbit ear kind of look. So you have an R and an R prime. This one you have a tiny R and an R prime. These are all different ones, of course. So this is a very tiny R, an S, and then a big R prime. But the terminal R wave is still more prominent than the first R wave. Once again, in this one, that's a good, nice, tall R wave compared to little r. Here you have a Q with a big R. These are all examples then of right bundle branch morphology. Left bundle branch characteristic, remember, it has a negative or an S wave. Now, and that's the primary thing. So here you have a wide complex, small tiny r, and then a big S wave. Now you have and then this is V6. V6 is not nice for conformation, but you don't have to have in V6, you'll see this double R wave, then you'll have an R and an R here in V6. But in V1, tiny r, big S, tiny r, big S. You notice we also have ST elevation there, which we're going to get to in a bit. So also in lead 1, you'll also get this double notch in the left bundle branch block, but you don't need it. To get through the night, all you need to do is look at V1. Okay, we're going to talk about Stemi monikers and mimickers in a minute. Uh, uh, but first talk about Stemi. By definition, Stemi is an acute ST elevated myocardial infarction is 1 millimeter of elevation in 2 or more contiguous leads. Now that's the trick, contiguous lead. You've got to know what contiguous leads are. And a STEMI should have symptoms of acute coronary syndrome. And usually you'll find reciprocal changes. Reciprocal changes are the mirror opposite leads. So the leads that are opposite to the leads that you're seeing ST segment elevation in. So commonly that's in the anterior leads, you'll see ST depression in the inferior leads. So now there's a normal evolution of a myocardial. A myocardial infarction goes on for, well, up to usually about 2 to 3 days of evolution. So here we have a normal, and then as you start getting into an actual myocardial infarction or STEMI, you'll end up start to get a rise in the ST segment. ST segment is the area just after the J point, just after not the J point, but just after where the R wave comes to the S where it comes to the baseline. So it'll be just slightly above, and you notice the T wave is hyperacute. You may not have much ST elevation here, but now as we move along, and this may be minutes, this may be a half an hour, whatever, you start to see a marked elevation of your ST segment. The T wave becomes a little less peaked and less acute. And then as this goes on over a period of time, and we're looking at perhaps 6 hours to 24 hours, you'll start to see a Q wave. A Q wave is pathologic evidence of a completed myocardial infarction. In other words, some of the muscle tissue has actually died. So our whole point of identifying the ST segment elevation myocardial infarctions is to get persons to the cath lab and get the culprit vessel opened by with a catheter and a balloon dilator, and then to stent this usually, so that we don't get to this point. Our point is to stop these people at this level here. Be nice if we could stop them at this level here, because so there would be minimal permanent damage from that. So this is going to go on. See the T wave is still up. Now you've got a fully developed Q wave. This is probably this would be going on at about 3 to 4 days. And usually you'll have the inverted T waves, which indicates there's still some ischemia in that area of the tissue, some leftover ischemia. And now then roughly after 2 weeks, you end up with essentially back to normal baseline for the ST segment and the QRS, but you'll have this permanent big Q wave. So when the machine reads your 12, a lot of times it'll say that you'll have a it'll say inferior myocardial infarction, unknown age, or something to that effect. And what it's doing is reading that there's a Q wave there. That is not an acute STEMI. That's reading a Q wave. It just indicates that, yes, probably they had a STEMI at one time, and they ended up with some permanent damage. Now, important then to know where the STEMI is coming from. And when you're looking at the 12 lead, the inferior leads are leads 2, 3, and AVF, with reciprocals then in 1 and AVL. High lateral is 1 and AVL, reciprocals in 2, 3, and AVF. Anterior is V1, V2, V3, V4. Now you can all put septal in, although it's not as important. Septal is V1. You almost never see just septal. It's almost always, but a lot of times you will see anterior that doesn't have anything in V1. Posterior, you see reciprocal changes. You don't see it doesn't generally show anything facing. So reciprocal changes usually in V1, V2, V3, V4, if you see any at all. But in my experience, most of the time you can get it. You can think about most of the time posterior is also associated with an inferior MI. So here we have an inferior MI. Remember, evolving changes in 2, 3, and AVF. This one has a nasty little Q wave in it too. So this may have been there for longer than it may have taken longer to get them to the cath lab than we wanted. So but you see 2, 3 AVF, marked elevation, and you see some reciprocal changes in AVL and in lead 1. Also in some lateral changes likely too. Another right ventricular myocardium. Now, right ventricular myocardial infarctions, in your orders, it will say if you have an inferior a STEMI in inferior leads, you to do a V4 or V3R and a V4R. This is because a fair number of cases, probably up to half of our inferior MIs occur because of occlusion of the right coronary artery. So the right ventricle is involved in this, although strictly speaking, when we say it's that means the inferior portion of the left ventricle has also been supplied by that right coronary. So in this case, so to do a V4R, or V3R, V4R, you simply take V3 from the left side, put that lead on in the V3 spot on the right, and then similarly for the V4. Turn that off. Now, an anteroseptal MI, you can see here's in leads V1, V2, elevation, V3, V4. So, and there's a little suggestion of ST elevation in AVL, which means it's probably a little lateral involvement as well. Through anterior MI, usually V1 is spared, and it is in this case. It's just there's no real ST segment elevation there, but you see rather marked ST elevation when you get into the V2, the V3, V4. Also, this one is definitely getting some lateral because you got V6 or V5. Let me go back then that one. Got V5 elevated, and also lead 1 and AVL. Here is a nice anterior, V2, V3. Here's V4, V5, V6. So now you're clearly anterolateral, and then confirmed by AVL. Now you also see all these nice reciprocal changes in the inferior leads. High lateral means you're involving only one AVL for all intents and purposes. There's really not much elevation in here. Doesn't make much difference. Most of the action is here, and you see some reciprocal changes in 3 and AVF, just confirmatory. So AVL in 1. Now, I haven't said much about AVR. If you have elevation of ST elevation in AVR only, this is interesting. That can indicate that can be a STEMI due to left marginal artery occlusion. However, that's the least common thing that you get from that. So in this case, this turned out to be not a left bundle, not a STEMI, but it's due to this was probably due to sepsis more than anything else, but this is certainly, and you notice that there's reciprocal changes in the vast majority of the rest of the leads, indicating probably ischemia, generalized ischemia. So, whereas we don't really want you to call this as a STEMI. I would bring that in as, still bring it in code 3 and say you've got ST elevation in only AVR. And if you can determine that the person has sepsis or a electrolyte abnormality, that's fine. But it doesn't mean that they're not deserving of a immediate evaluation by the physician. But this is not typical of a STEMI. So ST elevation can occur as along with the anterior inferior STEMI, but that you already are calling it a STEMI then. Usual etiology of ST elevation in AVR is repolarization abnormalities, hypokalemia, digitalis toxicity, shock and sepsis, hemorrhage, dissection, sometimes a PE that may indicate some right heart strain again. And acute coronary occlusion is only less than 10%. So odds are you may never see one, but call it if you see it and call it to the attention of the doc. That's one more piece of evidence that this is an acute problem, needs to be dealt with. So here is another example of this, and this one actually turned out, it's the only one I could been able to find in our treatment, in our list of cases. This was a ST elevation in AVR that did turn out. He didn't go to the cath lab immediately. Went to the cath. He was determined to be a non-STEMI, but went to the cath lab follow up and did have an occluded marginal artery. So it probably was acute. So he didn't have any other reason for it. Yeah. So.
Hey, Dr. Whitwer, real quick. What slide are you on right now?
Or
what number?
Are you not seeing it?
We're on slide 19. We're still on high. There you go. There you go.
Yeah.
Whoops, now we just lost everything.
Now we just lost everything on my end too.
Oh, that's okay. Go back to share screen.
Oops. I don't know why this keeps coming up telling me I have to share my. It's reloading it. It says There it goes. Okay, you back? Are we back?
Yep. Yep.
Okay. So did you not see those last? Okay. So that was the last couple slides that were on was ST elevation and AVR, and the most common reasons that happens is because of either left bundle branch block, LVH, hypokalemia, digitalis toxicity, or shock from sepsis, hemorrhage, misspelled hemorrhage, dissection, and acute coronary occlusion is only the minimal amount of it's less than 10%. This was one that I did find from our records that we did bring in, and it was picked up in the field as ST elevation and AVR only, but lots of reciprocal changes in the inferior and even in the lateral leads. And it was determined that the patient was not, the cardiologist thought that the patient was not having a STEMI, but because the troponin did go up, he took him to the cath lab fairly quickly anyway, and he did have an occlusion of marginal artery. So this was certainly, and he didn't have any other reason to have the uh, the the ST elevation, the ST elevation and AVR. He didn't have things like hypokalemia or DIJ or anything like that. So to recapitulate, what to look for in a STEMI is ST elevation of greater than 1 millimeter in two contiguous leads. So inferior leads, or so that automatically, you say, well, gee, if I only had ST elevation in lead AVR, I couldn't call it a STEMI because there's no other contiguous leads. So, but it's important to call it to the attention of the doc when you find it. Now, know where you're looking. So we need to be looking at, so this is the pocket card, which shows it off in nice colors. So, but inferior is 2, 3, and AVF. That's together. The high lateral is 1 and AVL. Regular lateral is V5 and V6. Anterior can be from V1, V2, V3, V4, and also anterior septal would include V1. So I've rearranged STEMI mimickers to the ones that count, because or in other words, the ones that are the most common. And so the most common of our STEMI mimickers is left bundle branch block, and also paced rhythm. And for all the same thing, left bundle branch, that means that the left ventricle is normally innervated by the left bundle that traverses down the ventricular septum. The right bundle goes to the right ventricle, the left bundle goes to the left ventricle. And the reason we have these tissues, these bundles at all, is so that the right and left ventricle are stimulated to begin contracting at the almost at the same time or at a timed interval, so that the contraction starts from the bottom of the ventricles and moves upwards, so that you can pump blood efficiently out of the ventricle. Now, when you knock out a bundle, so you knock out the left bundle, that stimulation that has come from the AV node goes to the right ventricle, and then because the left bundle is damaged and won't transmit, that the right ventricle stimulates the left ventricle to contract. So the left ventricle contracts that much behind the right ventricle. They don't contract together or synchronously. So that ends up giving you a wide, complex QRS. And in the case of a left bundle, remember that that in V1, the primary QRS, the primary wave is a downward reflection and a deep S wave. It's a deep and wide S wave. That is characteristic of your left bundle branch block. The other thing that's characteristic of a left bundle branch block is that often causes ST segment elevation, particularly in the right, in the V1, V2, V3 waves. But because that's a normal finding, we say with a left bundle branch block, we cannot read ST segment elevation except under a couple of circumstances. So this, for example, is a nice left bundle branch block, big S wave, also big S wave in that one. And you see quite a bit of ST segment elevation. Now, in a left bundle branch block, it is normal to have what is called discordance. In other words, the ST segment is in the opposite direction of the QRS. Concordance is not normal in left bundle branch block, meaning the ST segment is in the same direction as the QRS. So if we find concordance, that indicates there's a Stemi in that lead found. Now, here is this is one of the cases recently. A 64-year-old male complains of syncope after exertion. He was actually out, I think he was chopping wood or something. And he had a syncopal episode. When he came to, he complained of chest nausea. Hey, think of the context here. This puts him in pretty good. He was cool and diaphoretic. His blood pressure was 80/56. And they had to actually give him some norepinephrine en route for his hypotension. Now, your machine is reading him. The machine, in this case, says meets ST elevation criteria. Well, if you take away nothing from the, in this case, it's right. But don't always overread your machine, because the machine is often wrong. And doesn't put it into the context of the patient. This is, and they did call it an incomplete left bundle branch block. which I don't agree with. This is actually, it measures out wide enough to be a left bundle branch block. And but you see now, here you have an upright complex, and you have a large ST segment elevation, same as this one, large ST segment. So this one is an acute, and so this is concordance. You have upright QRS and an upright ST segment. Here you have upright QRS in lead 2 and a N1. This guy had a very massive coronary occlusion, and he actually got fixed. And he left the hospital some 3 days later with his stents in good condition. Now, here's another one. 70-year-old lady, abdominal complaints. The chief complaint was abdominal pain. Said it started in her left flank, went to her low abdomen. She says she told the medic that she had a normal stress test 2 years prior. She was on no medications except baby aspirin and Pcep. Blood pressure was elevated, 230 over 110, heart rate 120, O2 sats 99. She got some aspirin, some nitro, got some fentanyl, repeated blood pressure 145, 106. Her pain was better. The machine reads it as having an extensive infarct, age undetermined. Well, it's because but look at this. It also left it as, it didn't read the left bundle branch block. And she was called in as a STEMI. It was turned down by the ED doc who read it, who received it by the Pulsera, and did not call this as a STEMI. And indeed, contextually, this doesn't make any sense to be a STEMI, and you can't call it a STEMI if you've got ST segment elevation with a bundle branch block. She has some PVCs thrown in for good luck, lots of other things. She certainly needed to be treated, and her actual problem was she had renal colic. She had a kidney stone. Well, here's one that makes it, that the machine reads as meets ST segment elevation criteria. Look at this. A nice left bundle branch block. It even says left bundle branch block. So this is the case. You just have to overread this one. Obviously, this one came in as a STEMI as well. This is a 60 guy, complains of dyspnea, history of diabetes. He's on dialysis. He had a valve replacement in March of this year. Blood pressure was okay. O2 sats were 71, but they rose with 3 liters. His CO2 was less than 30. I'd say he was breathing fairly rapidly. And he, quote, diminished breath tones bilateral. This was called as a STEMI also. This was not a STEMI. This man was in acute congestive heart failure. And certainly was an ACS case, needed to come in urgently and get treated. I suspect he would have gotten better with a little nitro, and even though his blood pressure is low, I might have cautiously given that, or they heard RALs when he was in the department. Diminished breath tones, and he did have RALs, I'm sure. Okay, the next STEMI mimicker, next most common would be left ventricular hypertrophy. We see a lot of people with who have left ventricular hypertrophy on the basis of underlying coronary disease and hypertension. You see, this one is a normal complex, not a wide complex. So it's not a thing, but what you do is put the largest negative deflection in either V1 or 2, add that to the largest positive direction in either V5 or V6. So V1 goes with V5, V2 goes with V6. You add them together, and if they're greater than 35, then that's EKG evidence of left ventricular hypertrophy. You just look at this one and you know it's it's ventricular hypertrophy, and then look at the QRS that's associated with it, and the ST segment is markedly elevated, at least in the anterior leads, but that is easily confused then for being a STEMI. Next most common, acute pericarditis. How common is it? Oh, we see few cases a year. It's not that common. ST segment elevation in most leads, once again, except for AVR, and no reciprocal ST segment depression except in AVR, so it doesn't really count. So you see ST segment elevation in, well, these are lateral, ST segment in anterior, ST segment elevations in some of the inferior leads, and then the high lateral leads. Well, this would be the tip off. He has too many areas of the heart involved to be anything except a pericarditis, because you can't have an acute antero septal lateral inferior infarct, because the patient would probably not survive that. Benign early repolarization is actually reasonably common. I did not include that. I did not put that at the very beginning of common things, because it's not something that most medics are going to pick up on. But you should suspect it when it's a young, healthy patient, less than 50 years of age, and it has ST elevation most prominent in the precordial leads, V2 through the V5. And there is a little notching, little slurring of the J point. The J point is where the QRS, where the S meets, it hits baseline, basically. So there's a little notch there, a little bump, and that's the tip off that this is benign early repolarization, usually very young, healthy people. So contextually, you would say, well, this probably isn't a cardiac event. So here you see this little notching in here, a little notching in here as well. Don't see it as well as you would expect in those leads. So, but you see some that looks like it's ST segment elevation in the inferior leads. And now, ventricular aneurysms are rare. We've seen 2 or 3 of them in the multi years I've been doing emergency medicine in Vancouver. it's a bleb in the ventricle that occurs after an infarct. So the person has to have a history of having a recent infarct. And the bleb occurs when there's actually a full transmural infarct that occurred, and the ventricle is weak then at that point, and it bulges out, especially when the ventricle contracts and there's a pressure. There's a little, it's like an aneurysm, and it bulges out when the ventricle contracts, and that disrupts the normal vector course through that ventricle. So what you get with it is persistent ST elevation after the myocardial infarction, and it should when it should disappear. So you have a history of MI, patient is discharged from the hospital, complains of chest pain again, or complains of something that brings the medics out, and then you do the 12 lead and you see ST segment elevation, and you say, oh, he's having another myocardial infarction. Well, I'd probably want you to bring them in acutely at that point, and they need acute. Yeah, and if you call it an ST segment, if you call it a STEMI, I would not be upset, because you don't have evidence. If you'd had a continuous electrocardiogram, or you had an electrocardiogram that showed this same pattern when he was discharged from the hospital, then you might suspect that this is an aneurysm. But without knowing it, you have to sort of, if he was having chest pain, shortness of breath, and you saw this, I would be happy to have you call it. Just know that an occasional one will turn out to be a ventricular aneurysm. Now, in this case, you also see that he has quite it's a narrow complex, but it's quite a prominent S wave. This basically is the QS, and this is probably left over from his full thickness myocardial infarction. Now, this is not a STEMI mimicker. I just throw this in because this is a right bundle branch block, but with a right bundle branch block, the Q waves and the ST T changes are not altered by the bundle branch block. So in this case, you've got a terminal R wave, which is upright, so it's a right bundle branch block. It's a wide complex. So, and you can see this marked ST segment elevation, but because this is a right bundle branch block, you will call this as a myocardial infarction. Here's another one, terminal R wave. Actually, this one has a little notch in it too. And then you've got ST segment elevations in several places, and that is certainly an acute myocardial infarction. Now, we're going to talk about ACS a little bit, and to do that, we have to, the Washington State has had a cardiac triage tool that has been for sort of a way to help medics, or to suggest the medics to which hospitals you should take a patient to. Now, in our hospital, in our county, we only have the two hospitals, so we have designated one as the acute STEMI hospital. But both hospitals can take acute coronary syndrome patients with some caveats. Triage for acute coronary syndrome or STEMI is a three-step process, and it's in the, this is directly from the DOH website. Assess applicability for triage. So post-cardiac arrest with ROSC automatically is going to go to a STEMI-capable hospital. Or a patient greater than 21 years of age with symptoms lasting more than 10 minutes but less than 12 hours, suspected to be caused by coronary artery disease. So that's going to be chest discomfort, pressure, crushing pain, tightness, heaviness, cramping, burning, aching sensation, usually center of the chest, lasting more than a few minutes, or that goes away and comes back. Pain or discomfort in one or both arms, neck, jaw, shoulders, or back. Shortness of breath with or without chest discomfort. Epigastric discomfort, such as unexplained indigestion, belching, or pain. Other symptoms are sweating, diaphoresis, nausea, vomiting, lightheadedness. But note, women, diabetics, geriatric patients might not have chest discomfort or pain. Instead, they might have nausea, vomiting, back or jaw pain, fatigue, weakness, or generalized complaints. That's fairly vague. Now, the second part of the triage is assess immediate criteria. So post-cardiac arrest with return of spontaneous circulation, that's immediate. Hypotension or pulmonary edema, that's immediate. EKG positive for STEMI, if available, that is immediate criteria. If immediate, so any of those patients need to go to a STEMI-capable hospital. And then assess high-risk criteria. Now, this is what is known as the TIMI score, and I'm not, the TIMI score, it's TIMI, and it's an acronym for one of the studies that was done on it. And in addition to their original symptoms, these are criteria to sort of risk stratify the patient as to whether they have a high likelihood of morbidity, mortality. So first, they had to have the symptoms of that would make you think of ACS. And then you look at look for any four or more of the following. Number one, age greater than 55. That's an increased risk automatically to that patient to have some mortality from this particular episode. Have three or more cardiac risk factors, coronary artery disease risk factors. Family history, high blood pressure, high cholesterol known to them, diabetes, current smoker. Well, you can ask the patient most of those questions, and if they don't know they have high cholesterol, look at their list of medications, look at their medications for whether if they have high blood pressure, etc. So if they have three or more, they get a point for this. So they get a point for being over 55. They get a point for having three or more risk factors. Interestingly enough, they get a point for aspirin use in the last 7 days. when they put the STEMI thing together, that it turned out that people who took aspirin often took it because they were thinking they were having cardiac symptoms, and that actually was something that weighed into this TIMI score as being positive more often than it was negative. More than 2 anginal type events in the last 24 hours, including that episode. So if they had if they had severe heartburn or severe chest pain yesterday, and then in less than 24 hours they had another episode, that was considered probable angina and was a risk factor. Known coronary disease, a lot of people know they have coronary disease. They've had a history of it. Now, what about if they've had a previous MI and they have a stent, or previous STEMI and they have stenting and stuff? Well, that I would consider that known coronary disease as well. And then ST elevation of only 0.5, not 1. And of course, the ST deviation, and deviation could be elevation or depression, probably indicates ischemia. And it should be in 2 contiguous leads. Now, they also throw in the STEMI the elevated cardiac markers, but you don't have those available to you in the field. To my knowledge, there's only one place in the state of Washington where they're using cardiac markers in the field, and I'm not sure how that's turning out. But these, if your patient gets has 4 points on this scale, they are at increased risk for mortality and probably should take the patient to a STEMI capable hospital, because ultimately they're going to end up going to the cath lab. Then the general guideline is to take the patient to the triage to a level 1 cardiac hospital if you have reasonable trends. So in Clark County, that's what we do. This becomes more of a bone of contention in places where they have lots of hospitals, and lots of hospitals are vying for patients. That's not our problem. In Clark County, Pcep Southwest would be the receiving facility if the patient was at high risk for ACS and STEMI. Now, any ACS patient should be transported emergently to the closest, most appropriate facility. And so they go in, they go code 3. That way the physician will see the patient urgently on arrival. That doesn't mean, and we'll have a discussion later on, later on this year. That doesn't mean that all patients need to go. You don't have to have lights and sirens on constantly, because depending on the time of day, you may not need that sort of thing. But that's something we'll deal with at a different moment. Here's your Clark County protocol. Treat patients with chest pain, suspected to be acute coronary syndrome. Universal patient care, administer oxygen if needed, to keep the O2 sats between 94 and 98. Get a 12 lead. This may be done concurrently with other treatment. In a moment, you'll see that the KPI, the key performance indicator, one of the key performance indicator for coronary syndrome, and Stemi for the state of Washington is to get a 12 lead within 10 minutes of arrival at patient side. Aspirin, 324 PO, that's contraindicated only if they have a known allergy, active bleeding, ulcer, severe liver failure, or other systemic disease. Now, this should be basically baby aspirin because it's easily chewed, easily absorbed, and it causes the least amount of trouble. If your systolic blood pressure is above 110, nitroglycerin may repeat ×2 every 3 to 5 minutes. I notice the vast tendency around here in the places to give one dose of nitroglycerin and then go on to something else. That's not the appropriate way to manage chest pain that's thought to be of coronary syndrome origin. They should have a repeat dose unless their blood pressure falls. Now, there's a caution in a right-sided myocardial infarction. You've already proven if it does or isn't by doing a V3R or V4R in any inferior MIs. By caution, in other words, if they're elevated, if they have a blood pressure, if their blood pressure is 180 over 100, well, sure, you don't have any real problem with that. So I just would be cautious if they've got a low normal or a lower blood pressure. By low normal for the age, if you're a 50-year-old male and your blood pressure is 115, that's kind of low for a male. So I would withhold nitroglycerin at that time. Now, nitroglycerin is also contraindicated if they're taking any phosphodiesterase inhibitors, and there's a lot of them out there. And in the past 48 hours, if they took them before, if it's been a week ago, it's not a problem. Then if they're still having chest pain after a couple doses of nitroglycerin, fentanyl would also be indicated if you could not give them if you couldn't give them nitroglycerin because of the right-sided MI, if they're having pain. Now, once again, do that we'll keep it down to 50 mics per dose max. You can get a little bit of hypotension from fentanyl, but it's not as common. If they're hypotensive, you follow the shock protocol. Now, acute MI, STEMI suspected, that would be active chest pain for less than 24 hours, 12 lead EKG, elevated 1 millimeter or greater in at least 2 contiguous leads. No left bundle branch block or pace rhythm exception, and I put it right in the exception, except the left bundle branch with concordance in 1 or more leads. There are a few other ways to sort out whether you have a myocardial infarction associated with a left bundle branch block. Besides concordance, this is all part of the Scarbosa criteria, but the biggest bang for our buck is on concordance. We'll take care of most cases of left bundle branch block that could be associated with a STEMI. Will have concordance, and that's all you have to. The other criteria are kind of arcane and difficult to understand and to apply. Notify the ED of acute MI ASAP, provide care including aspirin, nitrogen, analgesia, transport emergently to Peace House Southwest for cath lab capability. And if the initial 12 lead is negative or inconclusive, repeat every 3 to 5 minutes if symptoms persist. If the 12 lead indicates an inferior MI, do a V3R and a V4R to evaluate for right-sided. Here are the key points for documentation according to the state for on the KPIs. Remember, key performance indicators, and this is what we look for when we're evaluating your charts. You want aspirin administration or noted contraindication. If they can't take aspirin, write it down, we'll find it. Acquisition of a 12 lead within 10 minutes of being at patient side. EMS scene time of 20 minutes or less for a STEMI. And then notification of STEMI alert and transport to appropriate facility. And of course, that's done primarily by Pulsera nowadays. So, but you'll indicate that in your chart as well. Patient goals for ACS is for acute coronary syndrome, to identify STEMI quickly, determine the time of symptom onset, activate the hospital STEMI system of care, monitor vital signs, cardiac rhythm, be prepared to provide CPR and defibrillation if needed, administer appropriate medications, transport to the appropriate facilities. STEMIs all go to Peace House Southwest. A non-STEMI, but acute coronary syndrome goes to the closest facility, closest, most appropriate facility. Patients who have a high risk, had multiple risk factors that you've identified through the TIMI scores. That patient should likely be transported to a STEMI capable facility. In other words, Peace House Southwest. If they have lower risk than any closest facility would be okay. So this is the end of this. Sorry that there was some problem with our transmission at one point. I'm glad we found it before we got into too many more things. Does anybody have any questions, issues that they'd like to bring up at this point? Take a look in the chat and see what we've got in the chat. Okay. All right. All right, with that, one of the things that has come up that people have suggested, and I think I and the other MPDs will work on putting together at least a quarterly, if not a monthly, STEMI or 12 lead review course using cases that come up in the county, and then some other interesting cases as they develop. We're also getting feedback from the hospital now, both on stroke and hopefully on STEMI, on any cases that are not identified as acute STEMI in the field, but turn out to be transported and turn out to be acute STEMI in the hospital. We haven't seen much of that. So at any rate, if there's any other questions, you can drop us a line into Teams or to our emails, and we will get back to you. All right, thank you.